thank you all for being here. We're really excited to have Dr. Mackey with us this evening to talk a little bit about women's health and some of the unique issues that Bahamian women experience. So without further ado, I am Kadesha. I am a volunteer with Equality Bahamas, and yeah, I'm a full-time student. So I'm always like I'm a learner of life, just happy to be here, happy to be with everyone to just, explore some, things we don't know yet about women's health. So, Dr. Mackey, I will give you the opportunity to go ahead and tell everyone a little bit about yourself.
All right, good night, everybody. Okay, I lost my voice, so I'm struggling a little bit here. But yes, so first of all, I always say I start off with saying that I'm a child of God. I'm a firm believer in God. And I'm where I'm at because of him. I'm a wife. My husband, his name is Taran, and he is the ambassador to Kuwait and Bahrain. I have four children, ages 12 to one. I have a 1 year old. So you might hear her running around and a little bit. Yeah, Michelle knows. Yeah, so I'm a doctor. I'm I'm a daughter, mother. I'm a daughter, sister, all of that. And I'm a physician. I'm an OBGYN. I recently finished my specialization last year, just recently, but I've been working at Princess Margaret Hospital in the Department of Obstetrics as a resident for over 10 years. Prior to that, I was in Jamaica for 3 years, worked as a senior health officer in the Department of Anesthesia, as well as in emergency department. I did my training in Jamaica. So in terms of what I'm a Sunday school teacher as well, at St. Christopher's. I've attended St. Christopher's basically all of my life. I'm a Sunday school teacher there. Um, I am a kind of a mini author. My daughter and I, we wrote a book called Savannah's Tiny Tea Off. She plays golf, and so basically it was just a book to inspire young girls and I mean girls of every race, but in particularly girls of color, to explore the world of golf. Yeah, so yeah, that's it. Mm-hmm.
That is amazing. Like you are amazing. I
Oh, thank you.
Yeah, I can't wait to hear more already. Well, I mean, so I want to say to our audience, feel free to put questions in the chat. Again, sorry, I should have said this, but this event is recorded. So we are streaming currently live on Facebook. It will be recorded and then we'll post this on YouTube. So if anyone in the audience would like to remain anonymous, we ask go ahead and use the chat. But yeah, so let's dive in, Dr. Mackey. I have so many questions. Um, my first one being like, how did you know? When did you know? What led you to a career in?
So my mom is a midwife. She works on the island of Abaco. I'm from Abaco, Abaconian girl, Crown Haven. Yeah, so she works in Abaco as a midwife. And so, I've always seen her and in a healthcare role.
Mhm.
Um, she often would have to fly back and forth to Nassau with her emergencies. So I've always experienced that. Now, I always knew that I wanted to, if not become a nurse, become a doctor. So I wanted to become a dermatologist. And I was in high school, I went and I worked with Dr. Hepburn in her office, just doing a little bit of filing, just to get to see what it was all about. And I said, okay, maybe I want to do plastic surgery. So I went and I worked with Dr. Neil in the office as well, but he would show me the little procedures that he did. And after I went to med school, I was like, okay, the dermatology plastics is nice. But it was, yeah, I kind of probably was my fourth year discovered that I really that I had an interest in obstetrics and gynecology. I don't know, I just kind of gravitated towards it. And two, I had some good registrars. They're the seniors and senior registrars, and one particular, Dr. Daly, Dr. Darrell Daly, who is still a big man, who was a very instrumental mentor in my life. He and another doctor, Dr. Chitrani Vikash, they encouraged me to apply for, it was a little scholarship, the Gibbons Award, to apply for it. And I did. I went ahead and I did, me and another medical student. And we were granted it, and it allowed us to go to ACOG. Basically, that's the conference for the field of obstetrics and gynecology, American Board of Congress of Obstetrics and Gynecology. And so we attended our first conference with medical students, and we got to basically, see what the world of obstetrics and gynecology was about. I got to interact with different medical students. And sorry, it was at that time when I was talking to different medical students, I found out that they had their own women's health group. And I was like, okay, what's this all about? You have your women's health group. And so it's a standard, and a lot of the American as well as European medical schools, that they would have this women's health group. So I was like, okay, well, we have to have one too. So I went back. When I went back, I got a group of medical students. It's myself, Dr. Astrid Batchelor, and Kimberly Nicholson, sorry, and she recently passed, unfortunately. But so we got together and we formed our women's health group. And we did different initiatives. So our focus was on adolescent girls in particular. So we would have like our Christmas parties, annual Christmas parties for the girls, and we would talk to them about sexual health, their bodies, etc. And we would have different outreach to different children's homes. And yeah, and we had monthly meetings for the medical students, basically just to educate them about, women's health issues. And, every month they have different topics on different women health issues. Yeah. So we did that in Jamaica. And so when I moved back to Bahamas, I was like, okay, well, I want to continue this. Yeah. So we still have it. And it's called the UE Women's Health Initiative. And that's been running since 2018. And
Okay.
yeah, and so every year a group of medical students, they come and they put forth their own initiatives, different initiatives, sorry. So it's exciting to see the students get involved, all of them, the different ideas and the different ideas and ways to give back. So it's exciting to see them and execute it. And so, yeah, so that's that.
That is so fascinating. I mean, I'm sure this women's health group was so needed because, like you said, like, I mean, that's pretty standard too in my experience of just being in higher ed, not necessarily being in medical school, but just being in higher ed. Like, there are these very like focused groups. And so, I can see how that would have been really, really necessary. I'm curious, like, what kind of initiatives in your time, like working with the group, either in Jamaica or in the Bahamas, like what sort of initiatives did you guys do or explore?
Yeah, so we, like I said, like we focus on adolescent girls, and two, that was also important for me, in the Bahamas as well, because so in Jamaica, we would have our annual, I can't remember the name of the girls' school that we would usually go to, but we did a lot of work with them. We had different campaigns, like we had the HPV vaccine campaign, basically to bring awareness about the vaccine and encourage women and young girls to take the vaccine. That's the vaccine that prevents cervical cancer. Yeah, so we're active in that regard. We're also active within the medical school because we would help the residents with their research studies. And yeah, just different things within the department we would have assisted with. So in here in the Bahamas, like I said, our focus is adolescent girls. So we work closely with the Adolescent Health Center and PACE. We have Christmas parties, annual Christmas parties for them. And basically we would try and bring the girls together, try to, a lot of them, come from homes um, that, is not the most ideal situation. So basically, to just bring some, happiness and um, happiness to their situation. So we would get them gifts. We would get a little package for the babies as well. And we also encourage the residents within the department, the obstetrics and gynecology department, to like if they to gather baby items. And they would also donate in different forms if it's monetary. And we would, have a nice Christmas meal for them. And then we have the residents come in and speak on different topics, sexual health. And we've also, over the past years, we've fortunate enough to have some persons who would have experienced teenage pregnancy, and basically they're now successful, with successful careers and family lives, basically to speak to the girls and let them know that, there is hope. So that's one of the things that we do. But like I said, every year the girls, well, not girls, the medical students, which comprise of both male and females, because we do have a lot of male medical students that are, very passionate about women's health. And so they've chosen different initiatives. One group, they did the period project where they raised sanitary pads, funds for sanitary pads, and they donated it to what do they can't remember the Women's Crisis Center, because they found that they needed that a lot of women would not have their personal sanitary items. Some of the girls, they the different homes they would,
Yeah.
and then the last group, they had a sexual health conference, and then they recently had a conference on what was it? Can't remember. It was on, oh, suicide, correct. Suicide, yeah. And actually the First Lady, Miss Anne Marie Davis, she was a keynote speaker. So yeah,
Yeah.
I'm very proud of them. Yeah, they're doing, a good job. Uh-huh.
I did come across the UE Women's Health Initiative through a friend because I know like she had been really into fitness, and I think that was like one year. Oh, I think one year there was like a fitness component, like a fitness challenge. I'm not sure.
I could take a minute here to plug Feminist Book Club, everybody. We have a lot of fun talking about books. The next meeting is October 16th, and we're reading A Mouthful of Salt by Reem Ghaffar. I'll put it in the chat. So you have 2 solid weeks to get and read this book, and it's available in hard copy, ebook, and audiobook. And yeah, audiobook makes it really easy. You can listen while you're doing laundry, cooking, whatever. In November, if you want to get ahead of the game, the meeting is November 20th, and we are reading The Resilience Myth, and that's by Soraya Chamali. And let you in on a little secret, she's going to join us for that meeting, which will be really cool. She's based in DC. She is like public thinker, feminist, has written for many publications, and she has roots in the Bahamas. So it'll be really cool to hear from her about her book, The Resilience Myth, and really talking about how the ideas that we have about individual strength and having to overcome are pretty ridiculous, and it shouldn't be a goal that we set, and we should be more focused on building resilient systems. So join us for those meetings. They're always at 6 p.m. And we meet via Zoom these days. It was in person. We might return to in person next year, but for now, on Zoom, you can sign up at tiny.cc/FBC 2024.
Okay. Well, you were just wrapping up I think your remarks about the Women's Health Initiative. And I was just saying, like, yeah, I had come across the Women's Health Initiative because I think there was like some athletic component. There was like some working out or something. And I was really pleased to see like, like groups getting together like that and just being like, okay, like this is important. We need to do this and supporting each other. So I love to hear that.
Mm.
You did mention this also a little bit there about your experience with mentoring, but I wanted to ask more specifically, like, what role has mentorship played in your life, either personally or professionally?
Yeah, so I mean, mentorship is extremely important in terms of, well, personally, like I said, my career decision was because of a mentor, basically exposing me and um, to the profession of obstetrics and gynecology, and also guiding me because, well, like I said, my that mentor that I had mentioned, he does cosmetic gynecology, and that's something that I've done further training in. And he, is someone that I can call on, that guides me in terms of, which particular, conferences to attend, which training, which further trainings that I should do. So very, very extremely important. And just other persons, I guess that my mother essentially was a mentor. She basically guide me, and she is there when I want to, I have queries or concerns, and she would say, "Hey, I did it this way. I had a bad outcome. Maybe you should do it this way." So basically, by the mentors expressing and saying, sharing their challenges, their mistakes, and just guiding you so that you don't make similar mistakes. So it's been very important for me. So I have lots of mentors, professionally, personally, and they've definitely help to, I guess, help me grow.
Yeah. That must be
Yeah,
so interesting too, to have, yeah, like your mom be a mentor, and to like you being in this profession now and her being a midwife, right? And just kind of comparing experiences from like a generational perspective. I can imagine how like interesting that must be. I know, essential. Yeah.
right. Yes, and too, and I know the doctors here, Dr. Butler, Holiday. They've all been extremely instrumental in terms of just guiding my career path. And I would have made probably a lot of mistakes if it was not for them.
Yeah.
Mhm.
You said something there too that I want to ask, that you kind of explained to myself and the audience. So what is cosmetic gynecology? Because I think most people, when they think OBGYNs, gynecologists, they just think like routine stuff, right? Or they think
Mhm.
cosmetic surgery. And so tell us a little bit about what the field of cosmetic gynecology is about.
Sure, yeah. So, I mean, with obstetrics and gynecology, that's just general women's health. Delivery obstetrics aspect of it is delivering babies. The gynecology is just dealing with, all of the gynecological organs, the womb, sorry, the uterus, cervix, vagina, etc. Right? And you have different subspecialties within that. So you have, you can do, I won't get into all that, but you could specialize, in cancer surgery, a gynecol oncologist, right? Um, and you can do it, you can be specialized in pelvic floor health, that's as well as urinary issues. With the urogynecologist, you can do reproductive stuff like in vitro fertilization and more hormonal, that's reproductive endocrinology. And you also have specialized persons that would deal with high risk pregnancies, and that's your maternal fetal medical specialist, right? Anyways, I said all just so I don't know if listeners are there to let them know there are different subspecialties within the practice of obstetrics and gynecology. Now, the cosmetic gynecology, called the field of cosmetic gynecology, is not a formal subspecialty, but it's one that's new and it's growing. So basically it deals with cosmetic stuff. So, for instance, with the I probably would have posted before, the vulva. You have the labia majora, which is the outer lip of the vulva. I don't have a model here to show you. The outer lips of the vulva, because the vagina is actually the inner part, but the outer part of the vulva. If that's with aging, it become a bit flat and lax, and so you can plump in that area. Another thing that you can do in cosmetic gynecology is vaginoplasty. That's when you tighten the opening of the vagina. And we have minimally invasive, so you can do it an in-office procedure. And for those that really have weak pelvic floor muscles, so persons who would have had multiple deliveries or who have had bad episiotomy repairs, then you might need to do a full-on vaginoplasty. Basically, that's just tightening the pelvic floor and the posterior aspect of the vagina. So that's something that a cosmetic gynecologist would do. They also will deal with things of with the different techniques like radio frequency, and so persons who have vaginal dryness, or persons who might even have medical conditions such as lichen sclerosis that causes vaginal dryness and pain. You would deal with treatments to help with that, with radio frequency, also newer treatments such as your PRP, which is platelet-rich plasma. That's when you would take blood from the patient, spin that blood down, use that plasma to inject into the vagina. And this can help with moisture, and it can also help with persons who have painful intercourse. Another thing that we would use the PRP for would be for O-shot. So O-shot is an orgasmic shot, and that is a lot of times with menopause, the hormones, they decrease, their fall. And so with the fall in hormones, you might have a decrease in sexual desire, and the orgasms may not be as intense and strong. So the PRP has a lot of the growth factors, and that basically you would inject that into the clitoris, and it would basically increase the sensation and increase the intensity of the orgasm. Other things that painful disorders as well. So if you have painful intercourse, we could inject Botox around in the pelvic floor muscle, so be the ani muscle, and through the labia majora, and that would help with painful intercourse dyspareunia. Other things that we deal with, well, so I do that, and I also like to do a lot of hormonal, with hormonal issues. So, and I guess that encompasses the whole menopausal, perimenopausal aspect of it, with the hormones changing, and by the use of the bioidentical hormones to help basically make a woman feel like herself and to get through that perimenopausal, menopausal period. Yeah, so yeah.
So I'm just curious because this is all so fascinating, right? Because like you hear a lot about like as far as like sex pleasure goes, like there's a lot of like male focused like research and effort and attention. And so like this all sounds very, like you said, I mean, you said it's a fairly new emerging field, but how would someone find a person like you, right? Like if I were just not knowing, having, let's say, some unpleasant experiences in the bedroom, and I wanted a better experience. Like, would I talk to my general practitioner? Would I talk to or if maybe I just had a baby, like, is this something that I should tell my OBGYN, my doctor, and they would know?
Yeah, and that's the first issue. A lot of women don't feel comfortable expressing these issues. But yeah, you should speak to your primary care provider. And if they now, I mean, some persons, because the field of medicine is so big, and you can't expect for, your general family medicine doctor to, have the tools to treat this. And even some general gynecologists may not have the necessary tools. But if you express it to them, I'm sure that they would do their research and refer to persons that may be able to assist. You know, for me, some things I might not be able to handle, and then I would refer to those that would be better able to handle it. So yeah, so just opening up, building a relationship with your doctor, and I'm sure as doctors, you know, we're trained to refer if we aren't able
Oh, no.
to.
Yeah.
Um,
But what
yeah,
about my insurance? Like, let's say I have insurance, or let's say I don't have insurance. Is this something
yeah.
that my insurance would cover?
No, insurance doesn't even cover contraception, right? So yeah, it doesn't.
I don't know, but wow.
Yeah, it doesn't. So we kind of disadvantage a lot, you know, in women's health. And even too, you know, speaking in terms of, you know, us being disadvantaged, the sexual health aspect of it, hormonal therapy. So men receive, like if they are having they have low testosterone. There are lots of studies that show the benefits of testosterone. So there are guidelines that would guide the administration of testosterone for men. So sorry. But with women, there are, you know, it's not we're not it's not studied.
Yeah.
We have limited studies dealing with hormone replacement. You know, we have studies dealing with hormonal replacement therapy, but there are the guidelines are is now they're putting some focus on it, and I guess you can see it now with the whole everybody's talking about menopause. There's a lot of menopause buzz, bioidentical hormones, because now you know, women are talking more about it, and they're finding now because of organizations like yourself, they are, you know, they're going and they are sourcing funding or um, basically voicing their opinions so that there can be change, there can be some funding to help fund these studies. And so hopefully soon in the near future, we can have you know, better guidelines in terms of treating things such as sexual desire in women. So we can offer testosterone replacement therapy for women. Because we do it, but we do it off label because there's no clear guidelines because of lack of, you know, sound studies. Yeah.
Tough.
Mhm.
Wow. And is that just like the field in general, like not specific to the Bahamas or anything? Is that like your general,
Yeah. What is that? What's the question?
the
Sorry.
lack of research and the lack of study? Is that what you see?
Yeah, and certain, yeah, in menopause, in sexual health, because you know it's just taboo. It's just taboo, and we feel uncomfortable expressing ourselves. Hey, you know, I have a low libido. We feel uncomfortable. Oh, I have vaginal dryness. We feel uncomfortable talking about those things. Because society has made us, you know, feel comfortable about women's issues, our periods. You know, it's you know, it's such a you know, shameful topic. We're ashamed of our bodies, and so yeah, but just generally, those things that I would have mentioned, menopause, sexual health, there's like I said, newer studies, but it definitely underfunded in terms of, and two, that there are limited studies. Yeah, the one big study that's the Women's Health Initiative, I think that was in 2002, might be wrong. But anyways, it was a study that was done then. It was a 20-year study done on hormonal replacement therapy on amongst women. That was one of the biggest studies. And that was a flawed study. Um, you know, we found that out several years later. And so that has affected um, physicians, we as doctors, that has affected our, we are a bit afraid in terms of administering hormonal or recommending hormonal replacement therapy. And so that's why a lot of women would suffer, you know, suffer in terms of the menopausal, perimenopausal period. You
Yeah.
can stop me if I'm talking too much.
Yeah.
Okay.
Yeah. Let me just look at the chat and see if we have any questions or if anyone is on mute and wants to um like ask a question, feel free to do that as well. But we are just, yeah, I'm just eating it all up because I'm just like, wow, like this is, like I said, your work is what drew me to just kind of learn more about, yeah, because I think you're the only cosmetic gynecologist or person in that space that I could think of.
Right, yeah, no, Dr. DePuche, he's also a cosmetic gynecologist as well. So he
Okay.
does, as well as Dr. Bodie in Grand Bahama. She, yeah, Bobby has some of the most vocal.
Maybe. And
Yeah.
I think too, like I think maybe that might be culturally part of our like problem, like you said, like it is still very taboo, like in general, but especially I think in the Bahamas, like there is a lot of taboo around talking about sex and it being satisfying for both parties.
Right, right. Yeah, yeah, yeah.
Interesting.
Hmm.
So what what well, let me ask you this first. How has being a mother, if at all, impacted your like relationship with women's health?
Um, yeah, so going through the whole experience of pregnancy, I can relate better to my patients because I've experienced some of the things that they would have experienced. Um, so and you're not gonna, yeah, I could say, oh, hey, yes, I know what you're talking about because I've experienced that. And going through the process of pregnancy, delivery, and the postpartum period, it the process has basically opened my eyes to what patients experience, and it has helped me to, I guess, identify areas that where I would have liked more information, or I would have liked a certain type of treatment, or I might have had a great doctor. But just it just helped me identify in terms of my practice how I would like my patient's experience to how I would like the experience to be. So it has helped me in that sense. Well, giving birth and all of that. Um, and then becoming a mother. Additionally, I think when you become a mom, your hormones change because I was never really emotional. My sisters they would always tease me. They would say, "Hey, Leanne is just she doesn't cry, et cetera, et cetera." But now that I've had kids, like I just cry like small things. I'm watching Moana and all this. I just cry. So it definitely made me more softer, and that has also helped with my bedside manners because I'm a bit more gentle. Because prior to becoming a mom, I my colleagues, my medical colleagues, when I was a medical student, they say, "Oh, you're so rough. You're so rough." You know? Yeah, so now I think I'm a bit more gentler. And also, I think that being a mother makes you a bit more observant and intuitive. So I'm able to pick up. So, in terms of my patients, seeing that they're saying they're okay, but I can look and say, okay, you're not okay. So it's because I have to look at my children. They say one thing, but I have to really look at them and observe their movements, mannerisms. So that in that sense, I think it has being a mother has um, helped me tremendously. It also has helped in terms of my faith. It definitely has strengthened that. So which also, I guess, would trickle into practice in women's health.
Mhm.
Yeah. Hmm.
I love to hear. I love to hear those life-changing experiences like being a mother because I do think like there are like things we go through in life that they really do soften us. I mean, they make us a better human, they make us more empathetic and just able to connect more. So I love that it was a positive, like it's had a positive impact for you.
Yeah.
I am so is that when you did becoming a mother inspire you to create your blog? Oh, okay. I'll let you answer and then I'll get this question from the audience.
Yeah, sure, no problem. What you mean the Bahamian Mom blog? Yes, it did. And I really need to get back at it, but just life has just been lifing. And but yeah, definitely I want to just create a platform just to discuss all things that we as women, deal with. And celebrating women, celebrating pregnancy, motherhood, all of that. So yeah, definitely it was, I think that was the birth of my daughter, Savannah. It's right after that, I got busy. I was like, hey, I had a light bulb and I said, hey, let me do this. And also with the Bahamian mom, I also um, had a shop as well, where you can just purchase. A lot of times you can't find a lot of things during the pregnancy period, like, the pillows or the teas and the belts and all that sort of stuff. So just basically a platform to be able to find those things more easily. Yeah, I mean, you can get them on Amazon, but just, to make it a bit more easier. Mm-hmm.
Well, Nia, I see you had your hand up. You want to go ahead?
Yeah, thank you so much, Dr. Mackey, for what you shared so far. I just had a question in terms of, I know you spoke about your personal experience of being more in touch with your emotions,
Mm-hmm.
after having children. And so that had me thinking about postpartum depression. And if you could give us a sense of what symptoms to look out for where it could possibly go into postpartum depression versus just like, I guess the normal run of hormonal changes. So how do you know the difference between, okay, it's just what happens versus like, okay, this is becoming postpartum?
Yeah, yeah, that is a great question, Mia. Thank you. So in terms of so when you deliver, during the pregnancy, for a healthy pregnancy, the hormones are high. So your estrogen is high, your progesterone is high. After you deliver, it just drops, right? As we know, hormones, the receptors are everywhere on our body, right? In the mind, in the brain, everywhere, right? And when they fall, then you will have symptoms, right? And so generally, after you deliver, in that first 2 weeks, you call them the postpartum blues. It's very common, right? Where you just feel a bit down. Because you just are getting adjusted to the baby. Your baby's crying up all night. Um, you so you you so you may not feel to do all the things that you usually would do, which is acceptable, right? Which is normal, and it happens. And most women may experience that blues. That's within the 2 weeks after delivery. You should not be exhibiting signs of so suicidal signs, or meaning that you want to kill yourself, hurt yourself, or hurt the baby, right? And you should not have any signs or, any suggestion that you want to hurt somebody else, right? Homicidal ideations. So those are, if a person expressed that they want to hurt themselves, hurt the babies, or hurt anybody else, then that's not normal, right? At any point. But if you are noticing that this person are having these symptoms are lasting longer than the 2 week period, then we need to be concerned that this is not postpartum blues that goes away, that this is leaning more to a postpartum depression. So the symptoms that the patient may have, so they don't want to do the things that they usually do, have appetite changes, right? So they may not be eating, or they may be eating a lot. They have change in their sleeping patterns, right? Sleeping a lot. They just generally they don't feel happy, right? They might be tearful, crying a lot. So those are the symptoms that you would look out, and especially if you having those thoughts of hurting yourself, hurting somebody else, or the baby, then definitely you would want to, if they're having those three things, hurting themselves, the babies, or somebody else, you definitely want to carry this person to the ER, right? Because that is an emergency. because and if they definitely have a plan to act on it, right? If they are just, generally they're not themselves, like I said, changes in their eating, changes in the sleep patterns, and they're tearful, crying a lot, then you definitely want them to see their OB and or a psychiatrist for treatment. And the treatment we psychotherapy as well as medicine. So basically, medicine. Sometimes you will need you in addition to therapy, you're gonna need some medicine to help with the symptoms. Yeah. So I hope that answered it, Nia. Very good.
Yeah, no, that was great. Thank you.
Okay. All right. Mm-hmm.
Can I piggyback off of that?
Yeah.
Okay. Hello, cousin. So if you are noticing these symptoms are lasting longer than the 2 weeks period, would there be, first of all, any tools that you would suggest to help, I guess, navigate it independently at home first before going to the doctor? Or do you think just go straight to the doctor first, and don't let it extend too long before going to see the doctor?
Right. So, in terms of, you as a patient or a family member?
Yeah.
Uh-huh. As a patient, right. So support is very important, just generally in terms of, your overall mood, right? But for me, just generally in terms of dealing with your emotions and too, this will help with the postpartum period, is I always recommend this. Are we paused? Are you listening? I think Michelle is pausing.
Maybe we're still here, yeah.
We're good? Okay. So I
There's
definitely
the person self-evaluating, let me just go and see my doctor.
I
We
think
had
I
lost
missed the
a
first
little
one.
bit.
Yeah.
Yeah, we lost
Wait,
you, Michelle.
did I
Can you
cut
repeat
off?
it? Yeah, can you repeat it?
Hello? Hold on, sorry.
Oh, well, we can hear her. Yeah, I think her connection might be unstable.
Okay.
Can you
But
hear me now?
Mhm.
uh-huh.
Okay. I cut off?
Yeah.
Yeah, you
Okay.
did.
What was the last thing you heard?
You were just asking me what can the patient, you as a patient, do to basically trying to navigate and help before I guess it gets to that point where you need to go to the doctor. Is that correct?
Yeah, or I
Uh-huh.
was thinking too as a partner. I know sometimes, maybe not
Uh-huh.
all men, but some men may feel helpless in these situations, right? They're witnessing the mother, like, I don't know what to do, how to help her. Is there anything that can maybe be done at home first before just being like, hey, I think we need to go see the doctor? Because you want to navigate the situation kind of gently and sensitively, and so I'm just wondering if there's any at-home remedies or techniques or tools to try first, or if you think the best course of action is to just go and see the doctor and have a conversation.
Yes, so if you are experiencing it, going to the doctor itself is therapy, right? Because you're getting it off
Mhm.
your chest and they can guide you. But generally, throughout the pregnancy and into the postpartum period, I always recommend self-care, right? So self-care, and I'm sure I talked to you about this before, but just making sure that your cup is full, right? And so just generally, we as women, what I would encourage people to do is like think about 10 things that makes you happy, that puts a smile on your face. And like I was tasked with this before and I found it so hard. I'm like, Lord, I'm doing things for everybody. And I don't know what makes me happy. And so that was a very difficult a very difficult task, right? And I sat down and I started writing. And when I started writing, the more things came. So on my phone, these notifications coming in. So basically, so for me, it was okay, like drinking a cup of coffee,
Oh, I
but
think,
talking to my sister. You can hear me?
yeah, we can hear you
Like
now.
talking to my sister, talking to my friends, like Shalia is on the phone on this call here. I was talking to my friends, like or going shopping or that's not oh gosh. really shouldn't be doing that. But going like exercising, going for a walk. Anyways, I write these things down, right? And every day you try and do 3 of those things. And even during your pregnancy, you try to do 3 of those things. So when you start your day, you start it up here, right? Because throughout the day, things are gonna happen that bring you here. But if you don't start your day here, if you start your day here, then at the end of the day, you're gonna be so low. So you have to start your day by doing these things. And then some days you're gonna need something extra because you with the hormones you might just feel a bit more down. Your body is changing and all of that. Baby's crying. If you have another child, they're pulling you this way, pulling you that way. So you might have to do some extra things. But throughout the course of the day, you just ask yourself, what it is, how do I feel? What do I need? And they say, how do I feel? Okay, I think I need a glass of lemonade, right? And then you go and you get that, and that might, that's going to put a smile on your face. How do I feel? I feel tired. Okay, well, go and take a 15-minute nap. And, that does wonders. Throughout the day, just checking in with yourself. How do I feel? What do I need? And then, doing those things, but starting your day by filling your cup up. And for me, that is, I have my coffee, I try and exercise, and I meditate, right? Meditate, pray. And when I do those things, I am happy. Like you can see the difference. And if I don't do those things, on the car, dropping the kids off, I am like, kind of miserable. So yeah. But I'm just saying during that postpartum period, it's a rough period, but just taking time for yourself, self-care. And for some that can help. And then others, the hormones are, they powerful, powerful things. You might not have, and in addition to actually, if you have that predisposition to mental illness, depression, so if you have depression, then, those things, they help a lot, but you might need something more. But for the, persons who don't have any, mental illness or the hormones are okay, then I find that those are some tools that can definitely help.
Yeah. Yeah, I think about, I think sometimes people, like you've said, like they don't have good support. Sometimes they go into pregnancy like completely unplanned.
Mm-hmm.
And I wonder if there are any like resources that are maybe not as popular, like people like that they're available in the Bahamas, but people maybe don't know about them that would be useful to mothers that are expecting or mothers that have recently joined the Motherhood Club, like navigating some of those difficulties that might not have really good support systems.
Yeah, so the in terms of the pregnancy, there are a lot of classes. The I think Doctors Hospital has a class. There are different classes that are out there, just basically to help you to just know what to anticipate. Because a lot of times, if you don't know what to expect, that kind of put the fear factor all the way up there, and you make you a bit more anxious, etc. So being aware, it kind of um helps you a lot. So that there are those things. In terms of the postpartum period, I don't know of any. I don't know if anybody in the group could say, but I don't know offhand of any support groups that help mothers and prepare you for parenting, because that's something that we kind of like we winging it. Yeah, we don't know what to do. You listen, but then there's the baby center that helped me significantly. That's a website, babycenter.com, and that basically tells you about what to expect with your child. So which different milestones that to expect, and it really helps you actually. Am I still? No, I'm not receiving alerts for my 12-year-old, but I'm receiving alerts for my 5-year-old to say, so what you expect, what to expect, what would you expect her to do at this point in her at this particular age. So that's a good resource, babycenter.com. Books, there are lots of books out there, but in terms of locally, I'm not aware of any support group.
Yeah, that's something I think we really need. We need the government to invest in because, yeah, we are very pro-life. And so we need to find ways to support life at all stages, you know?
Correct. And it's a very crucial time, very crucial time. We do have the 13 weeks, which is good, but even pushing for more time off so mom can spend, a bit more time with the children, that would even be better. And I think, and I think that's why that's why it's deteriorating. In the US, they have 6 weeks. Canada, I think it's longer, like a year, 2 years for some. In the UK, is different. But, with mothers being absent, not bonding, again, it causes a breakdown in family life. And that's not how it's supposed to be. And so, I mean, and you can see it. You can see it in terms of the children, and, it's definitely that's something that I think we should push for.
Yeah, most definitely, most definitely. So you have taken us through this wonderful journey of becoming an OBGYN, things you've learned. But what in this journey, if you can think of anything, if you can't, that's fine. But what have you learned about women's health as an OBGYN, as an adult, even before being an OBGYN, that you wish you maybe knew earlier, like at a younger age? Is there anything that you were like, I should have known this?
Um,
For me, it's cosmetic gynecology. Like I feel like I should have known.
no, no. Um, I think no, this is answering the question, but the period, like with my menstrual cycle, I ask my patients all the time. I ask them, oh, which age did you start seeing your period? And some people, most of them are able to give me, 12, 11, da, 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 right? But I kind of empathize with those that can't remember. They're like, oh, I can't remember because I can't remember. I can't remember, like, I don't know when. I can't remember the experience. I don't remember anything around it. I don't know if it was a bad experience, just blocks out my mind. But so that the whole, the, and I don't know, I guess this is not answering the question, not answering the question, but I, but I wish I had known a bit more about, as an adolescent, more about what to anticipate. Yeah, what to anticipate. And I think that a lot of times, a lot of parents aren't equipped with the tools to, to basically educate their daughters on what to expect. And I think I wish I would have known a bit more. Yeah.
Yeah. I can resonate with that too. I think like most of what I would have heard as a kid was always like from friends that also had their period already, like in fifth grade or something, like before the 11, 12 kind of average time. And
Mm-hmm.
it's strange, right? Like this thing that only women experience, women are not talking to women about, like young women about. It's so strange, but it's so true.
Yeah.
I see Michelle had a comment in the chat. She says, when should we start talking about women's health and sex ed? Do you have any thoughts about that?
Yeah, so I think we should start talking to kids about their bodies from early on. I just did a session with it was K3, and this is the second time I did a session with them. And we talked about we were labeling parts of the bodies. We talk about the vagina, we talk about the penis, and because we want to basically encourage them to use those words, good touch, bad touch, right? So from as early on, you want to make people, and two, it kind of helps them feel a bit more comfortable about their bodies. So from early on, you start to talk to them about it. And the pediatricians, they usually do a good job with this, and when you take them for their visits, okay, why not? But yeah, so from early on, you build that relationship. And so for girls in particular, because I did start my first gynae, I'm about to launch it. Basically, it's just a visit for adolescent girls to prep them on what to expect with the periods, talk about their bodies, talk about the different sexually transmitted disease when that time comes, and contraception, access of contraception, and just generally. So basically, like we were talking about in terms of if you are educated on certain things, you can anticipate it, and when that time comes, you can make better decisions, you know? And so the studies have shown that, in terms of sex education does not increase promiscuity. It actually helps when that time comes for persons to engage in sexual activity. It's they're able to make the better decisions, right? And two, the experience is more it's a better experience. So I think that having that open conversation with your children allows them and equips them and empowers them to make the right decisions. So yeah, so anyways, with my first gynae, it basically, like I said, this is just a visit to basically just make so they are aware of what to anticipate when their period comes, so that their periods, it is a, it's a good experience. It's not one that, okay, you're ashamed about, or you can't, like myself, you can't remember. You have your your period kit, and hey, this is normal. This is something. This is a process of me transitioning from a kid, a child, into adolescent, which is, these are all healthy, normal processes, and in preparing yourself for adulthood. And so, yeah, I think it's very important.
That
Mhm.
is so important. My young self inside is just like beaming because I'm like, I wish I had a you in this Bahamian education space when I was going through it, because like honestly, like it's normalizing the conversation, right? It's destigmatizing what every woman will go through at some point in their life. And it's just so wholesome, so necessary. And I'm so happy for you. Like I
Thank
wish you,
you.
yeah.
Thank you. Yeah, yeah. And I hope that, like with something like that, and not only for me, but that it would basically open a lot of parents' mind that, hey, yeah, maybe I should take my child. It's not to me, to a gynecologist. I'm not equipped with those tools to have that discussion. So whoever, if they feel more comfortable with their gynecologist, take their daughters to the gynecologist, let them have that visit, so that, hey, like this is normal, and they can start to build a relationship, so that if they don't want to talk to their parents, at least they have that person that they, may feel more comfortable to talk with. And so, and it just, it creates, a safe space, and children are more educated, and they then in turn will make better decisions.
Yeah, most definitely.
Yeah. Mm-hmm.
Oh,
Yeah.
yeah, that's just it's such important and necessary work. I'm just so happy for it. I'm happy that this generation of young upcoming Bahamian women will get to at least have some exposure to it, you know?
Mm-hmm.
Nia,
Yeah.
also a question. Go ahead, Nia.
Yeah, so something that I wish I knew more about was fibroids. So
Mm-hmm.
can you touch on that, please, Dr. Mackey? Because I know that's been
Sure.
like a huge thing, especially for Black women. People not recognizing symptoms, and just give us a little overview of that.
Sure,
Thank
no problem. Yeah, so fibroids, basically, oh my gosh, I don't have any of my models. I should not have done this at home. But fibroids, they are growth. They're non-cancerous growths that are on the uterus. So, that's your reproductive organ in the pelvis, right? So it's non-cancerous growth. In terms of the risk factors for it, well, like you had mentioned, it's more common in Black or, non-white individuals, because it's in the Hispanics as well. In terms of what there are environmental factors that could predispose you or increase your risk factors for fibroids. They've even said here the relaxers contain certain ingredients that may increase your risk for it. And so in terms of other the symptoms that you may have. So fibroids, you have different symptoms. You might have, and it's based on where the fibroid is located within the uterus. So if it's on the outside of the uterus, so if that means that it's probably touching on the bladder or in front or on the rectum and behind. Some persons may have constipation. Some persons may have bladder issues in terms of urinary frequency. It may compress on, you have some vessels that, pelvic vessels, it may compress on those pelvic vessels. And so persons who have fibroids, if they're big enough, it can cause varicose veins. And also you might have swelling within your legs, your lower limbs, right? So those are the compressive symptoms that you may have. In terms of you may have bleeding. So that's the most common. The persons who do have fibroids, they have heavy periods. Normal periods should last no longer than 7 days, and a normal period in terms of the amount of blood that you lose is 80 mils. Each sanitary pad can hold about 10 mils of blood. That's just a teaspoon, right? And so if you find, it's very small amount, right? And then you lose 80 mils over the entire menstrual period. If you find that you're using more than 8 fully soaked pads, then that's a heavy period. And so this is symptoms that you would commonly find with persons who have fibroids. Persons with fibroids also may have pain. So pain is another one of the symptoms that you may have because of sometimes the fibroids, when they grow so big, they might outgrow their blood supply, and then they start to degenerate, and that causes inflammatory factors to be released, and then you have pain. Oh, sorry. Back to the compressive symptoms. Another thing that can cause is GBT. So some persons who have clots in the leg, is because the blood is not flowing back, and the blood may pool there, and you might have clots. So that might be another presenting a way a person may present who have fibroids. So the pain, bleeding are the most common symptoms that you would have, and you may have those compressive symptoms that I would have mentioned. In terms of just diagnosing it, doctor will ask all these questions that I would have asked. Then you would examine. Some fibroids are very big. Some persons might look like they're pregnant. And then, in terms of confirming it, you can confirm it on an examination, which your doctor will request an ultrasound to confirm it. In terms of the treatment, there is you have surgical and non-surgical treatments for it, right? So usually, and the treatments is based on the symptoms that you would present with. Like I said, most persons may have the bleeding, so we would start with and as well as pain. We start with pain medication to help with the pain. They might have painful periods, as well as the oral contraception, right? Because the estrogen kind of feeds the fibroids, and so basically balancing the hormones helps with the bleeding. Excuse me. So we start with your oral contraceptive tablets that have hormones that kind of control the bleeding. Other things, there are other medications that you can use to help reduce the bleeding. So I feel like this is like talking to medical students. Sorry, sometimes you can't switch. But tranexamic acid to help reduce the bleeding, and there's non-surgical. There are tons of medication that we can choose from to help with the bleeding, right? But in terms of the surgical, I guess the other treatment modalities, you have stuff such as your uterine artery embolization, and that is offered at family medicine. And basically, you send basic particles through the veins to the vessel, that would supply the fibroid, and it causes shrinkage of the fibroid. It helps shrink, and you have to be a candidate for this, but it can help with the symptoms. You also have, you can have your other I guess, less invasive stuff. They have these newer treatments where you can do it laparoscopically. So laparoscopically, meaning that you're in theater, you're put to sleep, you have holes inside the tummy, and then what they would do is they would, put cameras down, but they have this it's called high intensity focused ultrasound that basically sends radio frequency energy to the fibroids to help shrink it. And you can do this above during the surgery. And they also have newer therapies now where you can do it below. So you are awake during this particular procedure, and they do it similar to doing a pap smear, and they put the probe through the vagina and into the cervix, and they can actually touch on the fibroid, and this radio frequent energy, it kind of causes necrosis. Like an egg, when you boil an egg and the protein coagulates, it causes the fibroids to shrink in that way. So that's another technique. And then you have surgery. You can have myomectomy when you remove the fibroids, and you have where you can remove the entire uterus, your hysterectomy. So yeah, so complex. Oh, sorry. Okay, well, I'll finish. Right done with that. Okay.
No, I was gonna say, so like, so is it perfectly fine to live your entire life with a fibroid?
I mean, if not causing symptoms, because the risk of malignant transformation is less than 1%, right? So there is a chance that this could turn from just a general, as a leiomyoma to leiomyosarcoma, which is a cancerous form, less than 1%. Can men get fibroids? No. Men can't get fibroids still in because men don't have uterus. This is the abnormal growth of uterine tissue. Yeah, but but so persons live actually during them, like I said, I told you estrogen feeds the fibroids. After menopause, when the hormones drop, there's less estrogen, the fibroids tend to shrink in some individuals.
Okay,
Yeah.
interesting. It's so interesting. But this is also something I wish that, we knew more about, talked more about in schools, because I know someone that had really bad periods when they were an adolescent, and when they got pregnant in adulthood is when they found out that they had fibroids. And,
Mhm.
like those two things were never ever brought up, talked about like with their doctor. And so I just think, it's just interesting. I mean, I'm sure she would have, and the person is fine. I mean, I'm sure she would have been fine either way, but I'm just curious, I guess, because they have had complicated pregnancies, um,
Mhm.
with no real reasons why. But I mean, they also haven't had their fibroids removed, and I'm not trying to say that's a reason, but I just wonder because of them having fibroids.
Yeah, very common, very common. I have fibroids, tiny, but yeah, they're
Interesting.
there.
Yeah. Yeah, I might want to go and see.
Yeah, but it's there, and if it's not causing a problem, I'm not too concerned about it. It's 2 centimeters, three, it's not causing a problem, then I'm good. But it's unless it's causing a problem, and for some it does it's very debilitating. So yeah.
Interesting. I wonder if like, aside from sort of like the cultural factors associated with Black women and how we live our lives and do our hair, like, are
And
there any?
remember,
Oh,
obesity also plays a factor in terms of estrogen.
okay.
Yeah, so yeah, when you have persons who are obese tend to have high estrogen, and hence like in our population, we find that we tend to experience menarche, which is seeing a period at an earlier age, because our adolescents are more obese, and so the actual adipose, the fat cells, they basically would cause more estrogen in the body, right? And so, and like I said, estrogen feeds the fibroids.
Interesting.
So weight has a very important part in fibroids and all of that, and your hormones, because a lot of times, even with conditions such as PCOS, which is a hormonal disorder, weight plays an important part. And so when we are treating it, we always start with lifestyle modification, which is weight loss. With all the hormones, they all, like if you come from the brain, the hypothalamus, pituitary gland, all of them work in tandem, all of your hormones. One is off, it kind of can throw other things off.
Interesting.
Yeah. Mm-hmm.
Do we have any more questions from our audience? Let's see. Don't be shy now. Y'all been asking some really good questions. So
I have a lot of questions, so I'm just going to go for one.
Okay.
Because we at Equality Bahamas have been doing research on the postpartum experiences of women, lots of different issues have come up, including postpartum depression and all kinds of other concerns and issues that don't seem to be identified by the doctor. Um,
Mm-hmm.
and I'm wondering about not just screenings, but also taking patients seriously. So just now we were talking about fibroids, and I think about things like endometriosis and how long it takes and how many doctors so many women go through before they get a diagnosis. So I'm wondering if you've seen any changes in recent years since we've been able to be more vocal and share our experiences on social media. Have you seen any changes in doctors, I guess, being more attentive and taking patients seriously when they're talking about pain and things that they know are abnormal about their body versus things that our parents might have had to deal with, our mothers in particular, with just being dismissed until years and years and years later, finding out, well, I was right. I have fibroids or some other issue.
Yeah, and that's a problem all around in terms of making that diagnosis. PCOS in particular is one of those things where you have to go to several doctors, several years to make that diagnosis. Like you said, endometriosis is one of those things. Fibroids, not so much. And I guess that's choosing, the importance of, you know, because your family doctor should do the necessary investigations, but sometimes that may not happen. But back to the question that you were asking in terms of, because it was a lot of questions that you asked, not one question. In terms of postpartum depression, making that diagnosis, right? Um, there are screening tools that we do. And in the Department of Obstetrics and Gynecology in particular, we try to actually, I had a study, one of my studies was comparing, I haven't, I haven't, I collected data, but I haven't compiled it as yet. But it was comparing adolescent postpartum depression to the adult population because adolescents itself they have different risk factors that they would experience. So just to find out if there was a higher incidence. But what it encouraged us to do is to ensure during that postpartum check. That's actually one of the routine mandatory things that we do at the postpartum check is to do our postpartum depression screen, and we do have guidelines that guide us in terms of, hey, what we assess for, when to refer. When do we refer to CCAC? When do we refer to the ER? And so, I mean, just as with every profession, there are guidelines, but it's up to the individual and doctors to do their due diligence and do their, screening. And what would encourage that is just doing, I guess, within the medical field, just more modules, more forums just to bring awareness to it and to educate the doctors on the importance of that. Um, so Alicia, what I didn't answer.
I
I
think
think
I think you covered it. Yeah.
Okay. But yeah, it's important. We do recognize it. I think that is something that needs to constantly, be hammered into our doctors, both the gynecologists and the family medicine doctors. I think the family medicine doctors, even with my PCOS study, they did a very good job, sometimes in some instances better than the gynecologists in terms of screening for certain things. So it's just education and constantly educating yourself, constantly keeping up to date guidelines, constantly being aware. And then just observing your patient, looking at, the patient come in tearful, observing the patients, and then they're, making the necessary referrals. Now, in terms of like I said, there's CCAC that you can refer to. During one of the things, I don't know if there's anybody on the call that can help me in terms of what there is out there in terms of the referral process for domestic abuse, because that's something that some persons might experience. Um, I know that there is the Bahamas, the Crisis Center, but are there any other organizations that you guys know of that in terms of domestic violence? Because that is something that's common, and especially in the postpartum period as well, and actually during pregnancy, because that's the point. During pregnancy, you're vulnerable. During the postpartum period, you're extremely vulnerable because your hormones have dropped. You feel fat. Your breasts are droopy, you don't feel yourself, you just feel a hot mess. And baby is crying, you're not getting sleep, so you're extremely vulnerable. And so sometimes the partner violence, domestic violence increases in that time, during that time. Do you guys know of any organization?
The Bahamas Crisis Center is the main one.
Mm-hmm.
And sometimes people get referred to social services, not the ministry, but the department,
Okay.
particularly if they need to be rehoused and things like that.
Okay. Thank you.
Well, I think we have time for one more question. It's in the chat. So Dylan is asking, do you have any takes on how climate impact, for example, heat waves, is affecting health, particularly for women?
How heat waves is, pardon me? Repeat that question again.
If you have any takes on how climate impact, he gave the example of heat waves, are affecting health, particularly for women.
Okay, thanks, Dylan. That's a good question. For women, the heat waves, dehydration, mood. I'm not sure if I'm answering this question great, but and I'm not sure if I'm interpreting this question.
I think it's just generally it's a general question about climate change. I suspect, like, there are certain populations like women that are particularly vulnerable in terms of like climate change, climate impact. And so I think that is this question.
Okay. Yeah, so I don't know of any studies, and that's something that I probably, I will go and look up. So thank you, Dylan, for that. But yeah, I at this point I probably I can't really answer that. But thank you for that, and I'll go and I'll do the research.
Yeah. Well,
Mm-hmm.
was there anything we didn't ask or anything you want to share before we give our final regards to our listeners, our audience?
No, just thank you for having me here. Thank you, Michelle, for letting your this group know
She
about
just she just big you up on social media. She just yeah.
Yeah, but thank you for having me.
Um
And
I do have one last question. I hope it's not,
okay.
but it's if you could share just one tip with with women anywhere to improve their health, what would it be?
Okay. So I guess that one tip would be in a lot of words. So that would be find a doctor, doctor that you resonate with, good doctor. Do your annual visits, right? Because when you do your annual visits and you build a relationship with your doctor, I think that we build a relationship with anybody, right? They know you, they get to know you better. And so when something is not right, they can pick it up quicker and they can act on it quicker. So you can, get your investigations quicker and prevent disease. It also encourages you by doing your annual visit, encourages you to know your body and know what is normal. And so you can be able to pick up when you're not 100% good. So so yeah, that's it. That's my tip. Do your annual visits. I am horrible with that. I just did one today. And I haven't done one, and I can't say in over a long time. Yeah, but
Yeah.
yeah, build a relationship, build rapport with your doctor. It's a partnership.
Yeah, that is true. That is very true.
Yeah.
Well, thank you so much for giving us this time. I know with the many hats you wear, you're a very busy woman, and so we really appreciate it. Um, yeah, thank you everyone for staying with us for this conversation with Dr. Agatha Mackey. We have just a few announcements before our feminist book club next week. There's a meeting, no, not next week, in 2 weeks almost, 2 weeks from tomorrow. It's going to be on October 16th. The book of the month is A Mouthful of Salt by Reem Ghaffar. We also have our climate talk series with Marjan scheduled, or it continues tomorrow at 6 p.m. on the Equality Bahamas IG and Facebook Live. So be sure to tune into that too. Women's Wednesday for November will resume back in person, and so it will be at the National Art Gallery of the Bahamas. You can sign up for our feminist book club using the links in the chat, and then you can sign up for our mailing list also with a link Alicia will be dropping soon. Thank you, thank you, thank you, everyone. I hope to see you all again at our next Women's Wednesday or any of our future events. Bye, everyone.